On the fracture, the basic principles of fracture treatment, the classification, and a bit about the diagnosis, and of course the treatment and the common complications. And I'm sure all of you are aware of what's a fracture. Fracture is a simple medical term for a broken bone. Of course, they occur when a physical force exerted on the bone is stronger than the bone itself. And of course, in a orthopedic day-to-day practice, majority of our cases are fracture and its complications. So the definition of fracture is a disruption or break in the continuity of the structure of a bone. As you can see in the X-ray, when you closely observe the cortex of the bone, at the middle of that bone, you can appreciate a fracture. There is a break. And sometimes the break may be involving the both cortices or all around the bone, or in some cases you can appreciate the fracture only on one cortex, what we call a unicortical fracture. So unless otherwise you are so particular in following this radiological pattern, you might miss this kind of unicortical or green stick, or some people call it as green stick fracture. So you should be very meticulous in following this radiological thing. So the reason for the fracture may be most of the time, majority of the time, it is follows a significant trauma. Sometimes a non-traumatic insult can produce the fracture, what we call the pathological fracture. So first we will discuss about the classification. There are a lot of classification. The simple classification or the commonly following classifications are anatomical classification, or according to the type of the fracture line, or according to whether it is a communicating or non-communicating to the external environment. So move on to the first classification, that's anatomical classification, that is according to the anatomical location of the fracture line. As for example, in a long bone, it is three areas we have basically: the epiphysis, the metaphysis, and the diaphysis. So you can describe the fracture if it is in the epiphyseal region, that is near to the joint is the epiphyseal region. You can say it's an epiphyseal fracture or epiphyseal injury. Or if it is in the metaphyseal region, that is a region between the shaft and the epiphysis, that is the metaphysis, it's a highly cancellous bone, trabecular bone. So you can call it as metaphyseal fracture, or it can be a diaphyseal fracture. Apart from that, the anatomical region can be, as for example, in this slide you can appreciate, you can see the picture of a tibia. There you can see the condyles, tuberosity, medial malleolus, all these regions are there. So if the fracture is in this region, you can name the fracture according to where exactly the fracture has, as for example a medial malleolar fracture, or lateral tibial condylar fracture, or tibial tuberosity fracture, etc. So that is the anatomical classification. I repeat, according to the anatomical area like epiphysis, metaphysis, or diaphysis, or according to the named prominences or areas of the bone. Again, for the treatment aspect, we usually name the proximal third fracture, middle third fracture, or distal third fracture for planning our treatment and selecting the appropriate implant. Move to the broad classification, open fracture or closed fracture. So I would like to ask the question to Dr. Gautam. Gautam, what is your idea about an open fracture?
So open fracture is something where the bone is, there is external injury where the bone is seen.
Yeah, that's excellent. That's a brilliant answer. So open fracture is the fracture, whenever there is a fracture, there will be a hematoma. So when the hematoma has a communication with the external environment, that is an open fracture. And closed fracture, there won't be any connection or communication. Open fracture, again, there are two types: from within to without, or from without to within. That means the first one is from within to without, means in the picture you can see the sharp end of the bone, it is piercing all the way from the muscle, the fascia and the skin, and that makes a communication, that is from within. From without is a fastly moving or a sharp object is made that wound into the fracture hematoma. So open fracture and closed fracture is the next classification. So in the picture you can appreciate in the top, you can see from within the tibia is pierced all the way and there is a lacerated wound over the skin. And the third one is, next classification is according to the fracture line. So here you can see a good number of pictures. On the picture A, you can appreciate a avulsion fracture. That means at the area of the insertion, the tendon or muscle, because of its violent pull, it avulsed the attached bone part. That is avulsion fracture. Picture B, you can see the comminuted fracture. Dr. Shushruta, what is your impression about or idea about comminuted fracture? What does it mean?
Sir, comminuted fracture means there are multiple fracture lines and the bone has a minimal displacement but at multiple levels, the fracture segments.
Yeah, you are correct. And comminuted means that is true. Multiple pieces. The multiple means it is more than two. In a simple fracture, you can appreciate picture C. You can see there is a proximal fragment and distal fragment. If there is another small fragment, butterfly fragment, it is a comminuted fracture. So there are more than two fragment is comminuted. More than two can be three or at any number. And comminuted fracture usually by a high velocity injury, and comminuted fractures are inherently unstable fracture. In the third picture C, you can see there is a transverse fracture and it is displaced as well. And the fourth one is green stick. Green stick fractures are a unicortical fracture on one cortex, and other cortex it will be intact but there will be some bend, and it's a pediatric injury, all of us know. And picture E, you can see an impacted fracture. That is, one fragment is impacted into another fragment. So in the picture you can see it's just like a transverse fracture and it is impacted, so it became stable. And the picture F, it is an intra-articular fracture. The intra-articular fracture, there is a fracture extending into the articular surface, so it's a epiphyseal type of fracture with a articular cartilage injury. The significance of intra-articular fracture in our treatment scenario is, intra-articular fracture, there will be bleeding into the joint. So there is a chance for the fibrosis and stiffness of the joint. So moreover, when there is a stepping of the fragment, that is a displacement of the fragment of more than 2 millimeter, there is the joint become incongruent, and there is a chance for the early wear and tear or osteoarthritis. So intra-articular fracture, if it is displaced more than 2 millimeter, surgical reduction and fixation is advisable and it is mandatory. And moving on to the picture G, you can see a longitudinal fracture. That is, the fracture line is extended in the longitudinal axis of the bone. And usually this will be in the flat bones like patella. Long bones, usually we do not get these kind of longitudinal fracture unless otherwise it is a iatrogenic or planned osteotomy. Longitudinal fractures are usually seen in flat bones like scapula or patella. In the picture H, you can see a oblique fracture. The fracture line is oblique to the mechanical axis of the bone, and it will be by a bending or a twisting type of injury. And picture I is pathological fracture. Pathological fracture means because of the small or trivial injury can produce a fracture provided there is some pathology. The pathology could be a localized pathology of that area like any lytic lesion, tumors, osteomyelitis, or a generalized pathology like any bone softening conditions like osteogenesis imperfecta, osteoporosis or osteopetrosis. And picture J, you can see the spiral fracture. Spiral fracture is because of a twisting injury. This is a highly unstable fracture. And picture K is stress fracture. Gautam, do you know the other name of stress fracture of the second metatarsal? Hello, Gautam.
No, sir. I don't know the second name.
No problem. That is a stress fracture of second metatarsal is named as March.
March fracture.
Yeah. Because the March, it is very common among the military people and policemen in the training camp. We usually get one or two cases in every month from nearby police camp. That is stress fracture. Stress fracture of the second metatarsal is known as a March fracture. Stress fracture of the fibula is known as a runner's fracture. It is associated with the long distance runners. And the picture L, you can see the transverse fracture. So, according to the fracture line, it is classified like transverse fracture, oblique fracture, green stick fracture, spiral fracture, intra-articular, all these things are there. Pediatric age group, you will get the green stick fracture. And I say the spiral, the oblique and the comminuted fractures are always unstable fracture. The transverse fracture can be, maybe it is a stable or unstable, but once you reduce the transverse fracture, it will be stable most of the time. Impacted fractures are, there will be stable fracture. So moving on to the next slide, there is another method of classification, simple versus complex. That's nothing but simple fracture or closed fracture, and they are associated with a low energy trauma. There won't be much injury to the surrounding soft tissue, the muscle, tendon, and all this tissue. That is simple fracture. So there will be closed fracture, less injury to the, or less trauma, less insult to the soft tissue. Whereas a complex fracture, in the picture you can appreciate, it's a comminuted, displaced, there will be sharpens, so naturally there will be injury to the joints, the ligaments, the tendon, and definitely they require intensive treatment and rehabilitation. So that's another method of classification, simple versus complex. And next one is whether the fracture is stable or unstable. So stable fracture occurs when a periosteum is intact across a fracture. So the periosteum can stabilize the fracture, particularly in children. So stable fractures can be, as we discussed, it can be a impacted fracture, or a transverse fracture can become stable. So even small physiological muscle pulling or muscle action cannot displace these kind of stable fracture. That is stable fracture, and you can stabilize an unstable fracture by either an external or internal fixation modality. So after your surgery, your unstable fracture can be converted to stable fracture. So the physiological movement cannot displace the, if the physiological movement cannot displace a fragment, it is said to be a stable fracture. Unstable fracture, of course, it's a grossly displaced fracture, or by some reason, if there is a poor fixation, then it is an unstable fracture. At any moment, it can displace by the physiological movement or joint movement. That is unstable fracture. The spiral fracture, the oblique fracture, and comminuted fractures are always unstable fractures. Now we move on to the clinical manifestation. When we get a patient, what happens after the trauma, after the fracture? They will be rushed into the accident and emergency department with a severe pain. The fracture pain is very, as the experienced people say, it's just like a myocardial pain. So there will be pain, there will be reduced function because of the, either in the lower limb, there will be inability to bear weight, in the upper limb, inability to use the upper limb. And another clinical presentation is guarding of the muscle. That is the mother nature's mechanism of splinting. When there is a small fracture or any strain or a sprain, there will be muscle guarding, so that the patient keeps the involved upper limb or lower limb in a relatively less, in a protected way. That is because of the guarding. And of course, in a displaced fracture, you can appreciate a deformity. Shushrudi, do you know the name of the deformity of college fracture? It is a dinner fork deformity.
Dinner fork deformity.
Yeah, excellent. That is a dinner fork deformity. And next clinical thing is the crepitus. Crepitus is nothing but it is a gritty feeling. When you are examining the fractured limb, you can appreciate a gritty feeling by the rubbing of the fractures each other. That is one of the definite sign of fracture, and it is described like you never try to elicit the crepitus because it is a painful experience to your patient. So it should be always accidental. And there is an interesting thing is that sometimes you will get a pseudo crepitus. You imagine you have a fracture of the tibia and your patient has osteoarthritis either of the ankle joint or knee joint. When you examine the tibia, if the moment at the time of moving your arthritic joint, you may feel, you may get the feeling of that gritty feeling transmitted from the joint. That is known as a pseudocrepitus. So pseudocrepitus is an evidence of the nearby osteoarthritic joint. And there is negative crepitus means in case of fracture, if it is impacted, you cannot appreciate the crepitus because it is stable and it is impacted. One fragment is impacted into another. So I repeat, the crepitus is a definite sign of fracture. Then of course, if there is a displacement, definitely there will be shortening. Usually we diagnose the trochanteric fracture and neck of femur fracture by looking the shortening at the ankle region. So there will be pain, there will be swelling, there will be guarding, there will be deformity, crepitus, shortening and reduced function. So these are the clinical manifestation. And when you see your patient in the emergency department, you should take a brief history of the accident and what exactly is the mechanism of injury, whether it is a road traffic accident or fall from height. As for example, if the patient presented with a calcaneum pain in the calcaneal region and fall from a height, you should never forget to examine the pelvis, the spine and the base of skull because these areas are usually associated injured area if the patient is fall from a height and landing on the heel. So that is the importance of taking a brief history in the emergency department. Moreover, if it is a fall or a road traffic accident, it will be a high velocity injury. So we do expect a complex type of fracture with a soft tissue injury. We do expect a comminuted fracture. We do expect a displaced fracture. So that is the importance of taking the history in the A&E department. And always never forget to look for the pulse, distal pulse before you go doing the splinting because vascular injury is the most challenging and dreaded complication of any fracture. So always look for the distal pulse. So the assessment will never complete without looking the neurovascular assessment. You see the color and temperature of the limb. If the limb is cyanotic and cold, there will be arterial insufficiency, cyanotic and cool or cold. Blue and warm in venous insufficiency. And you see the capillary refill by simply pressing over the nail bed. Usually in a normal individual, the capillary refill appear less than 3
2
seconds.
seconds.
Yeah, exactly. 2 or 3 seconds. Less than 3 seconds. Less than 3 is 2. And the peripheral pulses, as we discussed the peripheral pulses always, sometimes the dorsalis pedis may be absent in cases. Then you see the posterior tibial because dorsalis pedis will be absent as per the evidences in 10% of the cases normally. And you see whether there is any edema. Motor, sometimes it will be difficult if the patient is having multiple lacerated wound and all, he or she may not move the limb, and you can have a look for the sensation. Now, after controlling the pain of your patient with some analgesics and you splint the area, splinting is the best method of controlling the pain. And once the patient is stable, after stabilizing all the airway, breathing, circulation and all these things and splinting, the next step is radiological examination and radiological diagnosis. The commonest radiological modality, of course, it is X-ray, but we have the CT, bone scan and MRI. It has this CT, bone scan and MRI has its own indications. In the X-ray, we have one rule, that's a rule of two, that all of you should remember it always. What does it mean? Rule of two means whenever you get a suspected fracture, you should take two views, that is AP and lateral. That it should be 90 degree to each other. That is the reason why we are usually writing AP view and lateral view. What is the reason for that? In the AP view, you can see the medial cortex and lateral cortex, and you can appreciate the displacement in the coronal plane. And in the lateral view, you can see the anterior cortex and posterior cortex and the displacement in the sagittal plane. So unless you take at least minimum two views, you may not be able to assess these kind of where exactly the fragment is displaced, what is the type of the fracture line and all. And always we relate the distal fragment for telling the displacement. In this X-ray, you can see the distal fragment is, in the AP view, distal fragment is displaced laterally. On the lateral side, you can see the fibula. And in the lateral view, the distal fragment is displaced anteriorly. So, this X-ray we can see, it is a comminuted fracture. It is displaced anterolaterally. So, it is a comminuted fracture displaced anterolaterally. That is two views. Two joints means always you should ask for an X-ray with the joint above and the joint below, because you should anticipate a subluxation or a dislocation or an intra-articular extension of the fracture line into the nearby joint. And it is advisable to take the normal or the opposite side, because sometimes you may have to compare the opposite side. As for example, if there is a suspected condylar fracture or a intra-articular fracture or a complex areas like elbow or ankle, if you have some suspicion about the fracture or a displacement, small fracture, you are advised to take the opposite, the so-called normal side, and it's very easy for you to compare with the other side. So the rule of two, I repeat, two views, two joints and two sides. Now the CT scan is advisable in the complex areas like pelvic fractures, spine fractures, base of skull, or any, if you are planning to reconstruct any joint, CT scan is the best modality, particularly the 3D CT scan. So that you will get a preoperative good assessment of the size of the fragment, where exactly it is displaced, so that you can plan your implant, the direction of screw and everything. So CT scan for the inaccessible or complex area like periarticular or articular fractures, pelvis and spine. MRI scan is wherever you require better soft tissue delineation along with the fracture, MRI is mandatory. And MRI is very commonly and classically described for the spine injuries. There you can see the spinal cord, the roots, the dura, all these things you can appreciate. Bone scanning is another modality for diagnosing the fractures, particularly the occult fractures. And it is classically described for the scaphoid fracture. I'm sure you are all aware that undisplayed scaphoid, you may not be able to diagnose on the day one with your X-ray. So it is recommended to take the X-ray after 10 days in a suspected fracture of the scaphoid. So after 10 days, sometimes the fracture line may be visible. So in that situation, you can ask for a bone scan so that you can see the increased uptake of your radioisotope in the fracture area. In the picture, you can see a increased uptake in the radioisotope in the scaphoid area of that bone scan picture of the wrist. Bone scan, we are usually using the technetium 99 for the fracture detection. Now moving on to the pathophysiology of the fracture healing, the morphological sequence of the fracture healing has been described by Professor John Hunter way back in 1768. Gautam, are you there?
Yes, sir.
Can you tell me some other contributions of Professor John Hunter into the in this modern medicine? Any other contribution apart from the fracture healing?
Sir, can I answer?
Yeah, please.
Sir, John Hunter, sir, actually, Sir John Hunter enabled us to know the different stages of the syphilis.
Exactly. Good. Then, of course, he has described the Hunter's canal or subsartorial canal.
Yes, sir.
Then he's the person who described the popliteal aneurysm. It is the commonest aneurysm in the peripheral aneurysm in our body.
Yes, sir.
So John Hunter is a person who, before John Hunter, that is before 1768, some other scientist has described some part or some steps of the bone healing by increased vascularity and all. And he is the most distinguished scientist and surgeon of his day, who described the 6 stages of fracture healing that includes impaction, induction, inflammation, soft callus, ossification, and remodeling. Impaction is nothing but is the dissipation of energy from an insult, and the impact of the insult is proportional to the energy applied to the bone and inversely proportional to the volume of the bone. So, as for example, fracture is more likely to occur when the force is more and bone is small. So that is impaction. And the next stage, as per John Hunter, is the induction. It is a stage where cells that possess osteogenic potential is activated immediately follows the impaction. Then goes to the inflammatory stage, where all the inflammatory mediators are activated. There will be increased vascularity, neovascularization, and that followed by the soft tissue callus formation. That begins when the pain and swelling subsides, that usually after 1 week, particularly in pediatric age group. It contains cartilaginous tissue. That followed by the hard callus formation, that usually starts by 3rd week. So the cartilaginous covers the bone ends and the new bone unite the fracture. So this period corresponds to the period of clinical and radiological union. So hard callus, when the hard callus is formed, there will be less pain, and these callus give good splinting to the fracture area. And the last stage, or stage 6, as per the Hunter, is remodeling stage. That starts from a period of clinical and radiological union till the bone has returned to its normal state and potency of medullary canal. So, after the union, there will be good amount of callus on outside the bone and in the medullary canal. So, during the remodeling, the osteoclast, I would like to brush up your memory. We have 3 types of bone cells: osteoblast, osteoclast, and osteocytes. Osteoblast is a bone forming cell. Osteoclast is a bone resorbing cell. Osteocytes are actually the used osteoblast, and it do not have much function in our body. Actually, it is coordinating the function of osteoclast and blast. So in the remodeling stage, the resorbing cell or the osteoclast that is coming, and that is resorbing the excess callus over the bone and it is removing the excess callus inside the medullary canal as well, and it is bringing back the bone to its previous shape and previous alignment. That is the remodeling step. And this is again after the Hunter's era. This is the recent classification. Stages of fracture into 3 broad classification. All this classification starts with the letter R: reactive phase, reparative phase, and remodeling phase. In the reactive phase, we have the inflammatory phase, hematoma formation, granulation tissue. That corresponds to Hunter's Hunter's 2nd and 3rd. That is induction and inflammation. Then comes the reparative phase, where you have the callus, both the soft callus and hard callus, and the 3rd one is a remodeling we discussed. So this is the nutshell of the fracture healing. Stage of hematoma, that is immediately follows the bleeding and edema. Stage of inflammation, stage of granulation tissue, that is nothing but a osteoid or the new bone before mineralization, that is osteoid. That lasts for 2 weeks. Then stage of callus formation, the minerals are deposited in the osteoid is the callus. So unmineralized form is the osteoid, mineralized form is the callus. Then of course ossification, followed by consolidation. Then remodeling. So remodeling starts once the union is complete. That models to original shape and strength. So in the X-ray, you can very well appreciate the various stages. In the X-ray 1, you can see the fracture. In the X-ray 2, you can see there is a hazy callus all around. The third, there is a hard callus formed. The fourth one, there is a good amount of callus, it is united. And the fifth one, it is remodeled back to its normal shape and normal alignment. Now, fracture healing basically there are two types of healing, primary bond healing and secondary bond healing. Primary bond healing is nothing but, so before that we discussed all the stages of fracture healing, and I have shown these X-ray. Here you can appreciate the callus and everything, and that is the secondary healing. Secondary healing is nothing but it is healed by the formation of external callus. When the fracture is not rigidly fixed, when there is a physiological movement at the fracture site, there will be good amount of callus on the outside the cortex of the bone. It is formed from the periosteum. That is the external callus. So if the fracture healed by external callus, as shown in the X-ray of the forearm, in the ulna you can appreciate there is a swelling at the fracture site, external callus. That is a secondary healing. But in the contrary, if the fracture heals without an external callus, it is known as a primary healing. So how you can make the bone to unite by the primary intention? All the fractures united follows a plate and screw fixation is by the primary healing. So when you fix a fracture in a very rigid manner with your plate and screw, or when you fix a fracture with a intramedullary with a locking screws, it will heal without external callus. That is a primary healing. So stable fracture healed by primary healing, and all the stable fracture even without without fixation it will heal by fracture healing, and it is classically described with those cases treated by rigid fixation by plate and screw. So that's all about the primary healing. So primary and secondary heals by external callus, primary without external callus with a plate and screw fixation. Now we move on to the important part of the principle of the fracture treatment. These are the 4 principles of fracture treatment advised by the Association of Orthopedics right from 1990. One is a functional or anatomical reduction is the first step. So whenever you get a fracture, you reduce back to its anatomical position. That is functional reduction or anatomical reduction. The second step is stable fixation. So you make the fracture to a stable one so that it will heal by primary intention. The third one is preservation of blood supply. When you operate on a fracture area, you should respect the soft tissue, because the healing of the fracture is not from the bone itself, it is a joint process. The healing requires vascularity, and the vascularity of the bone is coming from the attachment to the bone, the muscle, the tendon, the interosseous membrane, all these things are there. So always respect and preserve the soft tissue and preserve the blood supply. That is the third point. And the fourth one is early and active mobilization. So once you achieve a stable fixation, on the day one itself or in the next day, you should start the mobilization, either a non-weight bearing mobilization, or if you feel your fixation is good enough, you can advise for a weight bearing mobilization. So I repeat, these are the 4 principles of fracture treatment: functional or anatomical reduction, stable fixation, preservation of blood supply, and early and active mobilization. So now your patient is diagnosed, and the patient, after the X-ray, he is there in your emergency room again. Now we know the principle of treatment. Now we have 2 modalities of treatment. One is a closed method of treatment, another one is a surgical method of treatment. Conservative method or surgical, non-surgical or surgical. So these are the 2 methods of treatment of fractures. How do you decide this particular patient requires surgery, that particular patient do not require surgery? So our principle is a anatomical reduction and stabilization. And if you are planning a non-operative method, after adequate anesthesia, by traction and counter-traction principle, you try to reduce the fracture. Sometimes you may have to manipulate the fragment. You apply the pressure in the opposite direction of its displacement. And once you are able to reduce the fracture, you put a splinting or plaster of Paris immobilization. So, Srud, what is the chemical formula of plaster of Paris?
Sorry, sir.
No problem. It is a CaSO4 half H2O, calcium sulfate, hemi-hydrated calcium sulfate. Sometimes you may get a multiple choice question from that region. Actually, it is derived taking from the gypsum. Gypsum is a calcium sulfate. When you heat the gypsum, half molecule of water is lost from the gypsum. That is a hemi-hydrated calcium sulfate. So I repeat, after the reduction, you immobilize the area with plaster of Paris splinting. Then you take another X-ray to make sure that everything is fine, your reduction is fine, your alignment is okay. And in the plaster, if it is stable, you can continue the conservative line of management. And if you are not able to reduce, or if you are not able to maintain the reduction, definitely you should go for a surgical fixation. There are definite indications for the surgery. The indications are like one, as we discussed now, difficulty in reduction, difficulty in maintaining the reduction, all displaced intra-articular fracture, all comminuted fracture, all pathological fracture. If there is any vascular injury, because in the vascular injury is a dreaded complication, you have to open the region, explore the vessel and repair. Meanwhile, you do the fixation of the bone. So vascular injury, and of course if there is any soft tissues are caught in between the fragments like a muscle, if muscles or a tendon or a nerve is entangled between the fragment, all these are the indication for fixation. So close reduction, non-surgical manual alignment, or open reduction. So these are the two methods, basic methods. Traction is another method of reducing the fracture. We have skin traction and skeletal traction. I think we will discuss in detail about this skin and skeletal traction in our coming classes. So immobilization, we discussed cast. In the picture, you can see various types of cast. The cast is named according to its anatomically it is named. In the first picture, you can see it is a below elbow cast. It is recommended for the fracture of lower region of the ulna, lower region of radius, wrist injuries, and metacarpal fracture. This is a BE cast or a below elbow cast. This is a above elbow cast or AE cast. It is recommended for the forearm bone fractures, elbow injuries. And these are all the spica, various types of spica for immobilizing the proximal femur, hip region. This is usually we give for the pediatric age group nowadays. And there are some other beautiful splint now we have. So rarely we are using plaster of Paris. If you are using splint, it is more comfortable to your patient, and it's very easy for maintaining the cleanliness of the perineal region. So these are all the various types of spica. This is a double hip spica. This is a single hip spica. And in the lower limb, again, just like the upper limb, you have a below knee cast and above knee cast. So this is the way we are naming the cast. Move on to the surgical fixation. Surgical fixation, we have two modalities again. External fixation and internal fixation. External fixation, again we have two methods. One is a ring fixator and another one is a pin fixator. Pin fixator, we are using either Schanz pin or a Steinman pin and connected to the tubular rod with the help of some clamps. So you can stabilize the fracture with a pin fixator. And the ring fixator is also known as Ilizarov fixator. This has been described by Professor Gabriel Abramovich Ilizarov way back in 1950. And the advantage of a ring fixator is that it will give you a 360 degrees of stability. All around it is very stable. So immediately after applying this Ilizaro or ring fixator, you can very well advise your patient to weight bear, because it will give a good stability all around. That's the beauty of Ilizaro. So external fixation is one method, and the external fixators are advised for open fractures. You imagine if you have a patient with a badly contaminated wound and a fracture, even after the debridement, you may not be able to put a plate or a nail inside, because contaminated fracture, there will be bacterial contamination and there is chance for infection. And if you put an implant inside, the bacteria can very well form its biofilm over this foreign body or over your metallic implant. So in those situations, after the debridement, you reduce the fracture and maintain the alignment with the external fixator only. So in a badly contaminated soft tissue, lacerated wound, external fixation is indicated. Similarly, if it is a highly comminuted fracture, if your internal implant cannot hold the fragment, these kind of Ilizaro or external fixator is advisable, and commonly it is for the contaminated, bad, open fractures. And next thing is the internal fixation. Internal fixation, broadly there are two types: extramedullary fixation or intramedullary fixation. Extramedullary fixation by your plate and screws, it is you are keeping outside the medulla, or your screws alone, and the intramedullary by your nail. In this picture you can see the tibia fracture and fibula fracture. The tibia is fixed with a intramedullary tibial nail. There are two screws on the top and one screw at the bottom distal fragment. So this is an interlocking nail. The interlocking nail has an advantage that will give you good stability not only in this plane, in the rotary plane as well. So that will maintain the length, that will give you good stability in the coronal plane, sagittal plane and rotary plane. So you can advise your patient to do the partial weight bearing on the day one itself. So I repeat, fracture stabilization, surgical stabilization is broadly classified to external fixation and internal fixation. External fixation is pin fixation and ring fixation. Internal fixation is extramedullary fixation and intramedullary fixation with your nail. Now we are moving on to the last part of this talk, the complications of fracture. The complications of the fracture are broadly classified to early complications and late complications. The early complications are common complications are hypovolemic shock, acute respiratory distress syndrome, fat embolism, infection, compartment syndrome, and neurovascular injury. Late complications are malunion, non-union, Walkman ischemic contracture, avascular necrosis, shortening, joint stiffness, pseudex osteodystrophy, osteomyelitis, myositis of cervical osteoarthritis. So all these are the complications. Hypovolemic shock. I am sure Gautam and Shishrud are general surgery students.
Yes, sir.
So you may be well aware of most of these things like shock. Shock is basically the hypoperfusion of the vital organs in our body. And hypovolemic shock is usually commonly associated with
pelvic fractures.
Pelvic fractures and shaft of femur. Pelvic fracture, there will be blood loss of around 2 to 3 liters. And femur, we do expect 1 to 2 liters. And in open fracture, even in other area with a vein or a arterial injury, even though it is having a very small wound or a small bone, it can lose a lot of blood. So hypovolemic shock, there will be tachycardia, all these things. I am sure you are aware about the shock. Yes. And ARDS or acute respiratory distress syndrome is a medical condition occurring in critically ill patient characterized by widespread inflammation in the lungs. So the hallmark of ARDS is a diffuse injury to the cells which form the alveolar barrier. So there will be surfactant dysfunction, there will be activation of the innate immune response and abnormal coagulation. So in effect, the ARDS results in impaired gas exchange within the lung at the level of the microscopic alveoli. So that's all about the ARDS. It's a very dangerous condition. So in the fracture the complications of fracture, or not only in the fracture, in any medical condition, early detection is the best thing. Early detection of complication is the best thing. So you should be aware about the complications of all the medical conditions. So infection is the another problematic situation. There is a funny question that who is the biggest enemy of an orthopedic surgeon? One of my students say another orthopedic surgeon. So the answer is like bacteria is the commonest, biggest enemy of any orthopedic surgeon, not only other surgeon, but the orthopedic surgeon, because once there is an infection to the bone, it is very difficult to eradicate the infection. Because inside the bone there are multiple lacunae, all the pits and the crevices, so it will lodge inside. So infection is one of the early complication, and of course if you are not able to properly treat the early infection, it can lead on to chronic infection or chronic osteomyelitis. And it is commonly associated with the open fracture, particularly the lower limb or a tibia open fracture. So the usual dictum is you do a good thorough debridement. Debridement means you remove all the dead and decayed soft tissue, you remove all the foreign bodies, all the mud, everything, and give a thorough wash with 7 to 10 liters of normal saline. As I remember one of my professor said during my post-graduation, dilution is the solution to pollution. So you do a thorough wash with a saline, 7 to 10 liters, you do a good debridement, and you start a broad spectrum antibiotic. So that is the way by which you can prevent the infection. So all open fracture require aggressive surgical debridement, and post-operative you can continue antibiotic. Of course, you can take some serous fluid or a tissue for the culture, and you can start the antibiotics accordingly if there is some infection. Compartment syndrome is another entity, and the patient should be, or the surgeon should be very much vigilant to diagnose compartment syndrome, because the diagnosis of compartment syndrome is most often it is clinical. Compartment syndrome, by definition, it is nothing but it is an elevated intracompartmental pressure within a confined myofascial compartment. So in our body, all the muscles are, or a group of muscles are, confined inside a myofascial compartment. So one region there is a bone, all around there is a fascia. So it is inside a compartment. Normally, in a sleeping position, a sleeping situation, the intracompartment pressure is 0 millimeters of mercury, or sometimes maybe 0 to 1. And during physiological movement, it may rise up to 3 to 5 millimeters of mercury. In the compartment syndrome, if it will go up, and you can measure the pressure with the help of some catheters. In the picture, you can see one type of catheter in which it has a needle. You can pierce the needle into the desired compartment, and you can see the measure on the dial. And if the compartment pressure is more than 30 millimeters of mercury, it is mandatory. We have only the one and only treatment is the fasciotomy. You release the fascia so that you can reduce the pressure inside the compartment. Otherwise, it can produce a compromise of the neurovascular function that will reduce the capillary perfusion into the muscle and to the even to the distal part of the leg, and you may lose the limb of your patient. So early detection is the important thing of compartment syndrome. How do you detect in the early period? So we have the 6 P's of compartment syndrome. These are the clinical manifestation. I'm sure you are all aware about this. During your graduation days, you might have learned all these things. The pain, yes, paresthesia, oculothermia, pallor, paralysis, and pulselessness. The pain means we do expect a certain amount of pain for every fracture. If the pain is disproportionately very high, and if the pain is not responding to your NSI, commonly NSAIDs, you should suspect the compartment syndrome. So disproportionately increased pain not responding to even to the narcotics, that is pain. Paresthesia is nothing but it is a feeling of pins and needles, tinkling, ticking, pricking, all this burning sensation is paresthesia. It is because of the problem with your sensory nerves. if there is a reduced vascularity or compression over your nerve, it can produce paresthesia. Poikilothermia is reduced temperature. Because of the reduced vascularity, there will be reduced temperature. Pallor, loss of normal color, but in Asian patients or Indian patients, it's difficult to see the pallor, particularly in black-skinned patient. But you can appreciate the pallor on the nail bed, and you can look for the capillary refill, that is pallor. And paralysis is it's a late stage, in the late manifestation of compartment syndrome. Once there is a ischemia and to the muscle, and or once there is a nerve damage, it will be paralyzed. Pulselessness, you may not be able to get a pulseless limb always. A bouncing pulse is an ominous sign, in fact, because in the early stage, if there is a compression over the vessel, there will be a bouncing pulse, and pulselessness will be also a late sign of compartment syndrome. So the 6 P's, I repeat: paresthesia, pain, poikilothermia, pallor, paralysis, and pulselessness. So when you suspect a compartment syndrome, and when you see this paresthesia, increased pain and all, you can just palpate the muscle or squeeze the muscle, and you can compare with the opposite side. In the compartment syndrome, it will be a bit more than a firm. Normally, the muscles are soft. So the basic 2 etiologies of compartment syndrome or the pressure are: the pressure is coming out from outside or pressure is inside the compartment. So the decreased compartment size by your splending or the cast or dressing, all this thing can produce reduction of the compartment size. So when you are suspecting a compartment syndrome, always you remove the splint or you bivalve your cast or remove the dressing and see whether it is getting corrected. And another reason is increased compartment content, that is bleeding and edema and hematoma can compromise the volume inside the compartment. So from outside it can produce the compartment syndrome, or from inside reason it can produce a compartment syndrome. So clinical manifestation, I repeat, because it's a very important thing. Absence of peripheral pulse is an ominous late sign. Stretch pain is an early sign. And myoglobinuria, again, once there is a ischemia to muscle, that's also a late sign. So in the clinical scenario, we usually do the stretching of the muscles. As for example, if you are suspecting a forearm flexor group of muscles or a volar muscle, you do the dorsiflexion of your finger or dorsiflexion of your wrist. It is for stretching the flexor group of muscle. If there is any increased pain, or if the patient is not allowing you to do the stretch, it is an early sign of compartment syndrome. So that is a stretch pain. So how do you give the care to your compartment patient? Prompt and accurate diagnosis is critical. Early recognition is the key. Do not apply ice or elevate the above heart level, because it is already in a compromised state. So when you see the edema in a suspected compartment syndrome, for the edema usually we keep the limb above the heart level, but in compartment syndrome you will never elevate because it is already in a compromised state. Treatment is remove or loosen the bandage as we discussed, or bivalve the cast, reduce the traction weight, or even you remove the traction. And when the compartment pressure, I repeat, if it is more than 30 millimeters of mercury, definitely you go for a fasciotomy, emergency fasciotomy. This is a picture shows a emergency open fasciotomy. You just cut open the skin, the subcutaneous tissue and the fascia. So if there is increased compartment pressure, you can appreciate the sprouting or bulging of the muscle immediately. And if we are not addressing the compartment syndrome, it will lead on to a Walkman ischemic contracture, that is the late state of compartment syndrome. Walkman ischemic contracture is a permanent shortening or contracture of the muscles, involved muscles, commonly seen in the forearm, resulting from the injury that give rise to clawing of the deformity of hand, wrist and fingers. May I ask you one doubt, Susrudo, what is clawing? Can you describe the deformity in clawing?
In clawing, for example, in fingers, there will be a excessive action of one type of muscles, Like when we get an ulnar claw, there is increased action of the flexors. So increase.
Okay, good. You can see in the picture there is a hyperextension at the metacarpophalangeal joint and flexion of the all interphalangeal joints, proximal and distal. So it is just like the claw of a bird. So hyperextension at the metacarpophalangeal joint, and I repeat, the flexion of proximal and distal interphalangeal joint is the clawing. And in Walkman ischemic contracture, apart from the clawing of all the fingers, you can see the flexion contracture of the wrist, and sometimes if the pronator group is involved, there will be pronation deformity. And the thing is that the muscles, if it is involved, the flexor group of muscles, there will be fibrosis and shortening or contracture of this muscle, and the effective length of this muscle is shortened. So when you try to extend the wrist joint, what will happen? The claw will be increasing because there will be a fixed tendon length phenomenon, what we call it like that. Fixed tendon length phenomenon. The tendon length and muscle length is fixed. It lost its capacity to stretch. So when you extend the wrist joint, that means when you are trying to stretch the tendon and muscle, it will not allow you to stretch. And when you apply more force to extend the wrist joint, at the expense of the movement at the metacarpophalangeal and finger, you can extend the wrist, but automatically there will be flexion of these regions. So it will increase the clawing. So that is known as the Walkman sign. And when there is a Walkman ischemic contracture, that's a late complication of fracture. The surgeries are basically to two types. One is a muscle or tendon lengthening surgeries. You release the muscle from its origin. It's a max page surgery. You release the muscle from the origin, or you can do a Z lengthening of the tendon. That is a muscle or tendon lengthening surgery. And another modality is osteotomy. You reduce the length of the radius and reduce the length of the ulna, and you fix it. So when you reduce the length of these two bones, the effective length of the muscle or tendon will be increased. So that is the osteotomy and shortening of the bone and muscle and tendon release. So these are the two basic principles of treatment of VIC or Walkman ischemic contracture. Deep venous thrombosis or DVT is another problem we come across. It's an early complication, and being the surgeons, I am sure Gautam and Susud are very much aware, and probably you may be treating all this issue. And do you know what is a Virchow's triad?
Endothelial injury, stasis, and hypercoagulability.
Excellent, excellent. So that is the three reasons why there is a, most of the time there will be the venous thrombosis. So veins of the lower extremity pelvis are highly susceptible to thrombus formation after fracture, especially hip fracture or a proximal femur fracture. And precipitating reasons are, as you said, the Virchow's. And you can prevent it by giving anticoagulant medication in those cases if there is a high chance for this venous thrombosis formation. Fat embolism syndrome is another early complication. It's characterized by the presence of free fatty acids or fat globules in the tissue and organ after traumatic skeletal injury, commonly seen with the femur fracture. Particularly, it's a displaced comminuted fracture. These free fatty acids will be entering into the vascular system, and it can damage all the vital organs, and mainly it will be affecting the brain, the lung, and the skin, and of course the kidney as well. So the fat embolism syndrome, the tissues most affected are the lungs, brain, heart, kidney, and skin. And there are various criteria to diagnose. In the picture you can see in the chest X-ray, you can see there is a haziness all the way. That is because of the fat embolism and ARDS. In the brain, there will be ischemic changes. On the skin, you can appreciate the petechial rashes, particularly in the axilla, in the neck. And in the eye, inferior palpebral region, you can appreciate this palpebral petechial lesions. So in next time when you are going to your ICU, trauma ICU, you just see this region. This is the commonest, most commonly or earliest region where you can appreciate the petechial region in a suspected case of fat embolism. As per the literature, the fat embolism incidence is 100%, but it will be a mild variety. Sometimes it will be presenting like fracture fever, immediately follows a fracture, or within 48 or 24 to 48 hours there will be a small elevation of the temperature, and the researcher says it is because of a mild variety of fat embolism. In such cases, in your ICU, trauma ICU, you can appreciate these kind of petechial rashes in the inferior palpebral lesion area. So commonly it will be mainly it will be affecting the brain. So there will be disorientation, altered behavior, all these things. The lungs characterized by tachypnea, hypoxemia, all these things, and of course the petechial rashes on the skin. And the most accepted criteria to diagnose fat embolism syndrome is the GERD criteria. There are 4 major criteria and 7 minor criteria. I'm going through the major criteria. Axillary or subconjunctival petechiae we discussed. Hypoxemia, PaO2 less than 60 millimeters of mercury. CNS depression disproportionate to hypoxemia, and pulmonary edema. So petechial rashes, skin manifestation, lung manifestation, CNS manifestation are the major criteria. Minor criteria, tachycardia of more than 100, and usually it will be between 100 and 110. Pyrexia, emboli present in the retina on fundoscopy, fat globules present in the urine, a sudden inexplicable drop in the hematocrit or platelet value, increased ESR, fat globules present in the sputum. So these are the 7 minor criteria and 4 major, and you can very well diagnose a fat embolism when there is a 1 major plus 4 minor. So that is the commonly using criteria, the GERDS criteria. So the clinical manifestation usually occur within a period of 24 to 48 hours after injury in the form of pneumonitis or ARDS, chest pain, tachycardia. All these things can be there, and always you should suspect the fat embolism, otherwise you may not be able to diagnose at the early stage. The treatments are basically directed towards the prevention. That is, whenever you get a polytrauma or a displaced fracture, the 0-hour fixation, or you should go for a fixation on the day 1 itself, so that you can prevent the fat embolism. Because once you stabilize the fracture, the chance of free fat globules or free fatty acid going into the circulatory system is found to be less. And if you are not able to stabilize the fracture because of some other comorbidities, careful immobilization with some splinting or some other modality is mandatory to prevent the fat embolism incidence. And treatment is basically, it is a supportive, symptom management, fluid resuscitation and oxygenation is the most important one. So you give nasal or a mask oxygen, and once the oxygenation is going down, you may have to put your patient in the ventilator. And fluid resuscitation is also important. So that is a method of treatment, and there is some role for the steroid, and it's a debatable thing. And the next complication, we are moving on to the late complication. It's a malunion. Malunion is, that means it's a bad union. Mal means bad, malaria, bad air. So malunion is when the fracture is united in its, not in its normal anatomical position. I repeat, when the fracture not united in its normal anatomical alignment is a malunion. Whenever there is a malunion, and if it is not an acceptable malunion, definitely you have to correct the malunion by a corrective osteotomy. Otherwise, it can produce a shortening, it can produce reduced function of the limb, it can produce early osteoarthritis of the nearby joint. So these are the 3 problems of malunion: shortening, poor function or reduced function, and early wear and tear or osteoarthritis. So the treatment is a corrective osteotomy. You take appropriate wedge of bone from the either from the from the convex region, and you correct the deformity and fix it with some implants. Or you can do a open osteotomy, that is putting the osteotomy on the concave side, and you correct the deformity and you can fix it. The problem of open wedge osteotomy is that there is chance for non-union. And if you do a closed wedge osteotomy, you are removing a wedge and you are closing that wedge region. So the bone contact is good. So the chance of non-union is less. So that's all about the malunion. Non-union is another problem for every patient and every orthopedic surgeon. Non-union is nothing but it's by definition the physiological process of union come to a standstill. Clinically characterized by painless abnormal mobility and radiologically characterized by sclerosis of the bones. There is a defect at the bone region, fracture area, closure of the medullary canal, poor callus. All these are the radiological findings. So I repeat, non-union by definition, the physiological process of union comes to a standstill, clinically characterized by painless abnormal mobility and radiologically characterized by sclerosis of the bone end, closure of the medullary canal, there is a space or a defect at the fracture region, poor callus formation. The non-union is broadly classified to hypertrophic non-union and atrophic non-union by Weber and Chech way back in 1976. It is nothing but hypertrophic non-union means in the picture, the blue picture you can see, there is a fracture with a good amount of callus all around, but it is not united. You can appreciate the fracture line in the picture. So hypertrophic non-union, the biology is good, the bone formation is good, the osteoblast is doing its job very nicely, but the stability is lack or stability is poor. So hypertrophic non-union, there will be good amount of callus formation, but the stability is poor. So the treatment is very simple. You stabilize the fracture area either with a intramedullary or extramedullary device, implant, and you need not put the graft because it is not because of the problem of the callus. So stability alone is required as a treatment of hypertrophic non-union. Whereas atrophic non-union, both the biology is poor and the stability is also poor. So you have to do a rigid or a good fixation, and you require cancellous bone graft for enhancing the healing. In the bottom X-ray you can see hypertrophic non-union with a good amount of callus all around, fracture line you can appreciate, and the next X-ray is a atrophic non-union. There is no callus at all, the bone ends are thin and tapering, you can appreciate, there is a closure of medullary canal. So this is a atrophic non-union. These require fixation and cancellous bone grafting. The next complication is
so I just like to ask you one question. In which of the fractures it's most common to get a non-union? We get frequent MCQs in MRCS regarding the same, sir. Can you please clarify on this?
That's a good question. So non-union, the reason are maybe local reasons or generalized reasons. Local reasons are diaphyseal fractures are likely to go for a non-union because the vascularity of the diaphyseal region is less as compared with the metaphyseal region, number one. Second, open fractures there is a high chance for non-union because for the fracture healing, we all know the hematoma is very much important. The third one, when there is an infection or osteomyelitis, definitely it will go for a non-union. When there is a soft tissue interposition, it will go for a non-union. And then of course, if it is a pathological fracture, if there is a local pathology, that will reduce the healing would be less if there is a local pathology like tumor, malignancy or something else. So pathological fracture also go for a non-union. And regarding the sites you asked, some region, some area, there will be blood supply will be precarious. There will be some alteration of blood supply. As for example, the neck of femur fracture, intracapsular fracture, you know the blood supply is coming from the trochanteric region to the head of femur. So when there is any fracture, the blood supply will be affected. So it is not coming from proximal to distal as in all other area, but it is coming from distal to proximal. So the proximal part, that is the head of the femur, is deprived of its blood supply. So the chance of non-union is very, very high, number one. Another area of non-union is a scaphoid fracture. Scaphoid waist fracture, again the blood supply is coming from distal to proximal. So when there is any fracture, the chance of non-union and avascular necrosis is very high in the proximal region. Another area is a talus fracture. So these are the three areas where non-union incidence is very high when there is a fracture, even if it is an undisplaced fracture.
Thank you, sir.
Do you have any other? Then of course general factors like nutrition, general debilities, other comorbidities, nutritional deficiency, hormonal imbalance, hypothyroidism, all this can produce non-union. Area-wise, these are the three areas. And now we are moving on to the next complication, reflex sympathetic dystrophy syndrome. It is also, the old terminology is pseudex osteodystrophy, and the latest terminology of reflex sympathetic dystrophy is complex regional pain syndrome. This is of course, this is not an early complication, it's a late complication. The basic pathology of reflex sympathetic dystrophy is the dysfunction of the sympathetic nerve system. And this is reported in around 5% of all traumatic injury, particularly in upper limb injuries. And of course, it is possible in the lower limb as well. It may occur following fracture to the extremities, joint sprain, or following small surgeries. And it has been reported following immobilization as well. It is thought to be caused by the dysfunction of sympathetic nerve system, which is involved in the regulation of blood supply to the affected part. So, what are the symptoms? There will be burning pain, there will be hyperesthesia, there will be swelling, the skin becomes shiny, there will be stiffness. And when there is all these problems like pain, swelling, stiffness, automatically the patient will not move that affected part. So what happens? There will be muscle wasting, osteoporosis and stiffness. So this is a vicious cycle. Once there is muscle wasting and stiffness, the patient again will not move the part. So it will lead on to the stiffness again. So these are the symptoms: stiffness, osteoporosis, skin becomes shiny. So you can easily diagnose. There will be hyperesthesia. The treatment is basically a drug treatment, pharmacological and non-pharmacological. The pharmacological NSAIDs and short course of corticosteroids and tricyclic antidepressants are very commonly prescribing drug since the patient has all this sympathetic nerve system issue. And sometimes you may get a multiple choice question, and if you have this answer or choice or option of tricyclic antidepressant, it should be your first answer, like amitriptyline. And physiotherapy includes aggressive physiotherapy, and the most suitable one is a TENS or a transcutaneous electrical nerve stimulation. That's the best method of physiotherapy to reduce the pain and to enhance the mobility of the involved part. Myositis ossificans again is another complication. Myositis ossificans, of course, I'm sure you are aware that it's an extra-osseous non-neoplastic growth of newborn, and it is formation of bone tissue inside the muscle after a traumatic injury to the area. It's very commonly seen following the supracondylar fracture and commonly seen in the brachialis muscle. So the question from this region is, which is the commonest muscle involved in myositis ossificans? Your answer must be brachialis. It can affect any muscle in our body, and brachialis is the commonest one, and that condition is known as the fencer's bone. And sometimes it will be affected the adductor of hip, and that condition is known as the rider's bone because it was commonly associated with horse riders. That horse riding, you know, there will be chance for the injury to the adductor, hip adductor muscles, and there is chance for hematoma formation, the adductor longus or adductor magnus or ossification, that is a rider's bone. Here it is fencer's bone, your brachialis. So these injuries usually result of the acute deep muscle bruise or repeated muscle trauma to the same area. And the basic mechanism is the inappropriate differentiation of fibroblast to the osteoblast. And if you take an X-ray in the early days, you can see the fluffy calcification, also known as the spotted wheel appearance. You know, the spotted wheel of some dress, spotted wheel, because there will be fluffy calcification. And if you take an X-ray after say 1 month or 4 months, you can see the mature bone as seen in the X-ray in my slide. And histologically, if you take a small tissue and look under the microscope, you can see the Ackermann's zone phenomena. This is an important question for your multiple choice. Ackermann's zone. Ackermann described 3 zones. In the inner zone, you can see the atypical mitotic figure. The middle zone, you can appreciate the osteoid. And the third, outer zone, you can see the mature bone. So I repeat, innermost zone, atypical mitotic figure. Middle zone is a unmineralized bone, that is osteoid, and outer zone, it is a mature bone. And I will tell you an interesting thing, that sometimes the surgeon or a pathologist have the confusion that whether it is a myositis ossificans or a osteosarcoma. This can be differentiated both radiologically and histologically. The histological differentiation is that in myositis ossificans, the most mature part is the outermost zone. But in the osteosarcoma, the outermost part is the immature or the aggressive part. So that is the way by which we are differentiating. I repeat, myositis, outermost part is mature. Malignancy, outermost part is immature. So malignancies are always immature. So moving on to the treatment, in the early stage, you should immobilize the region to relieve the pain, reduce the edema. So immobilization for a couple of weeks, you can give NSAID. Indomethacin is said to be the best NSAID because it has the ability or capacity to reduce these kind of ossification or heterotopic ossification. So among the NSAIDs, indomethacin is the recommended drug for controlling or preventing the myositis ossificans. Even some surgeons are recommending the indomethacin in the early days of complex traumas. And of course, once the pain is subsided after 2 or 3 weeks, you advise for aggressive physiotherapy. Start with a gentle physiotherapy and moving on to aggressive physiotherapy to prevent the contracture and to enhance the mobility of that region. And by this slide, I think thank you very much for your patient hearing, and that is the last slide. And I hope you all enjoyed my class, and if you have any doubt, you can ask me.
Hello sir, good evening. This is Dr. Sushrut.
Sushrut.
Yes sir, I would like to ask you one question. Actually, it's not related to the fracture presentation, sir. So most commonly we are getting questions regarding the exposure of the axillary artery, sir, while doing shoulder joint surgeries. So I just wanted to ask you, the question which was asked in this April exam was, which is the first vessel which we encounter during mobilization of the axillary artery while doing anterior approach for the shoulder joint?
The anterior approach of shoulder joint is a deltopectoral approach. That is the plane between the deltoid muscle and the pectoralis muscle. Okay?
Yes,
deltopectoral approach. The deltopectoral groove, you have one vein, it is not an artery, that is the cephalic vein. And a deltopectoral approach is the safest plane, and you will never see any other vessel or any other artery. Directly you will entering or landing on the anterior part of the humerus. And through the anterior approach, you cannot see the axillary artery. Axillary artery is in the axilla itself. It is the medial part of the shoulder joint. What was the question? Are you sure it is artery or something else?
No, sir. They have asked, while it was a question for the trauma actually, in an emergency situation you want to do a cut down for axillary artery. So what all vessels do you see when you do the cut down? And the options were given. when you want to do a cut down for the axillary artery?
I think I will check it out, and in the next class we will discuss about it. And to my present knowledge, axillary artery, you can see the nerves. So you have the brachial plexus all around, because
Yes, sir.
usually we are giving the axillary block. My residents are always giving the axillary block, and we have the nerves, axillary vein, and axillary artery. No other vessels, named vessel or significant vessels are in front or in relation to the axillary artery. I think you have the axillary
Yes, sir.
vein and the brachial nerves alone. And I will check it out, and in the next class definitely we'll have a short discussion about it. Okay?
Yes, sir.
I just want to ask about crepitus, sir. Pseudo crepitus and negative crepitus. I didn't got that point exactly.
Yes. It is, we discussed, it is a gritty feeling. It is a definite sign of fracture. It is nothing but the rubbing of fracturants we discussed. And pseudocrepitus means when there is an arthritis, advanced osteoarthritis, even if there is no fracture, when you try to, while you are examining or moving the limb, you can appreciate the gritty crepitus of the arthritic joint, and you may mistaken that this is the crepitus of the fracture, that is pseudocrepitus. Negative crepitus means if the fracture is undisplaced, if there is a fracture and if it is impacted, and if there is a fracture with a soft tissues in between like muscle or some tendons in between, you cannot appreciate the crepitus. So impacted fracture and soft tissue interposition, you may not be appreciate the crepitus even if there is a fracture. So that's a negative crepitus. Okay, is it clear?
Thank you, sir. Thank you.
Okay.